Hi everyone, thanks for listening to my presentations. Today I'll be talking about tuberculosis. That's a very big topic, right? And you must have heard about TB, okay? But I'll start with epidemiology and pathogenesis. And I'll tag this as chapter 1. I tagged that as chapter 1 because we have many things to talk about and we cannot exhaust that during this presentation. If not, it will become boring because I'm not going to keep you sitting down for 1, 2 hours, even 3 hours talking about one disease. With that in mind, let's go. Epidemiology. Mycobacterium tuberculosis is one of the Mycobacterium tuberculosis complex. And here I have examples as Mycobacterium africanum, bovis, orygis, caprae, Mycobacterium microti, Mycobacterium tuberculosis humanis. Mycobacterium africanum is found in West Africa, specifically in Gambia. It has symptoms similar to Mycobacterium tuberculosis. More than 1.5 billion people are infected worldwide. Incidence peaked in 2003, but luckily is declining right now, although very slowly. In 2018, the World Health Organization revealed that 10 million people were infected, and they also reported that 1.5 million have died of it. More cases in Africa, India, Bangladesh, Indonesia, and so on. The Central and South Americans are not immune also, but they have less trouble compared to Asia and Africa. Lesser cases are found in Western Europe, Canada, Japan, and Australia. I'll soon go into details why we have disparity in all these things. And that is the epidemiology. That's what we call resurgence. Resurgence is mainly due to prevalency of HIV infection. Also due to poverty, because poverty will lead to malnutrition and overcrowding. And those are the factors that will promote the spread of tuberculosis, HIV, poverty, heavy drug use, yeah, and of course poor sanitation. Europe experienced decline, and why is that? Because there's improvement in socio-economic status of their citizens. Europe have improved nutrition, they have improved living condition, and over the years, they've isolated all identified cases. World Organization has a target that we should end TB in 2013. That is the target from World Health Organization, and that has started since 2016. Who says? Someone is laughing, saying, oh, the dog is asking me, who says? I didn't mean a question. Who here means World Health Organization says. Says what? That 30% of people who died due to TB were never diagnosed or they were never treated. And World Health Organization also says that active case findings are needed. So when there is suspicion anywhere that there is a TB, then we must find those who are really having pulmonary TB, coughing, sneezing, and singing around right now. Okay? Then we have to be using sputum for nucleic acid application tests yearly for 3 years in people that we suspect around. Then latent TB screening is very useful. World Health Organization in 2015 released a guideline on latent tuberculosis infection, its identification, and of course, the treatment of the same. What are the possible risk factors? The risk factors are broadly divided into two. Is either impaired immunity or what we call host factors. Now that's going to be dealing with those who are old or on chemotherapy, having cancer, steroid usage, chronic renal failure, diabetes mellitus, or taking certain medications that like disease-modifying anti-rheumatic drugs that could suppress the immunity, or there's poor nutrition somewhere. Then the second factor will be exposure to the pathogen or the environmental factors. Overcrowding, somebody is having active disease around, coughing and sneezing around, and the sputum is just displays everywhere, droplets, aerosol inhalation, and so on. HIV, someone is bothering me now saying, what's the problem with HIV? You are presenting a topic on TB, tuberculosis. What the heck is this? No. Yes, you're right to ask me such a question, but the truth is, if we don't take into account the prevalence of HIV, we will never get the affected people with with TB out of their problems. Why? HIV seroconversion leads to depletion of TB-specific T helper cells. So both HIV and TB are targeting cellular immunity. And know the meaning of that? Double barrel. The further the drop in T helper cells, the higher the risk of tuberculosis and the more the severity of the same. I think you got that right? If HIV will lead to drop of T helper cells, then the lower the level of T helper cells, the worse the situation for the affected person who would have been infected with TB right now. And if that is the case, the more the severity of the infection. So it means TB could quickly kill that person right now. TB can be unmasked. If someone with HIV is taking medication to treat the HIV, that is highly active antiretroviral therapy. Okay? If there is latent tuberculosis infection, or is latent for a long time, but there's reactivation, okay, and the person is now having HIV on top of that, wow, then the risk of TB and death will increase. TB increases the progression of HIV to AIDS. You could see there are two flames that are damaging the host at the same time. Okay? HIV and AIDS are targeting T cells, cellular immunity in one host at the same time. So it's either the HIV is depleting the helper cells, making TB to be able to thrive the more and destroy the human being that is infected, or TB is increasing the rate at which the affected person now having HIV will go down the hill and develop acquired immune deficiency syndrome, AIDS. And when that is the case, when TB increases the progression of HIV to AIDS, then there will be death because TB will increase HIV viremia. And even TB on its own could cause death. Relapse is greater with TB and HIV combination, of course, for obvious reasons. And the situation is worse for anyone with HIV having tuberculosis and the CD4 count is low. All doctors will agree with Benda who measure the progression of HIV using CD4 count and some other parameters, but CD4 count mainly. TB pathogenesis. Mycobacterium tuberculosis will cause TB. Aerosol inhalation of droplets containing Mycobacterium tuberculosis through coughing. That's why Nowadays, we're talking about COVID-19, and then we need to cover your cough, cover your sneezes, dispose them properly. The same with tuberculosis. Coughing, sneezing, speaking, and singing. Not by handshake, except if somebody has coughed into the hand and shakes your hand, and you use the hand, you put this something in your food and you swallow. Okay? And when you inhale the droplets, it will go into your lungs. And when it gets there, what will happen? Let's go. On getting to the lungs, it can be immediately cleared off. There can be immediate clearance of those organisms, of tuberculobacilli. But primary disease with the onset of an active disease could also set in. The person could then become actively diseased and be coughing, hemoptysis, weight loss, fever, loss of appetite, malaise, night sweats, and so on. And the first two may not happen. We can get to the third stage of what may happen, could become latent. Just sit down there at the apex of the lungs, because they need air, right? They're aerobic, okay? They need air. So reactivation may occur later on, okay? Reactivation leading to an onset of a latent tuberculosis, and this is enhanced by HIV and other immune suppressing factors. Maybe this person is now taking steroids, glucocorticoids, DM, chronic renal failure, cancer, chemotherapy, radiotherapy, and all the sorts, disease-modifying anti-rheumatic drugs and everything, and immunity is down, or even just because of some other disease situation in the person, and the person is malnourished. And now the latent will now become active. That's what reactivation. The primary disease will occur in the first 2-3 years following acquisition of the aerosol. Okay. Once the tuberculobacilli reach the alveoli, they can establish themselves as latent TB infection. If not strong enough immunity, because if the immunity is strong enough, it's clear it off to fight it off. But if it's not strong enough and it's not cleared off, then proliferation will start inside the alveolar macrophages, okay, and migrate to enter other tissues. Tubercle is found in the lungs as a granulomatous structure, and a granulomatous structure will contain phagocytic cells, monocytes, alveolar macrophages, and neutrophils. When tubercle enlarges and bacilli enter the local draining lymph nodes, you obviously know what is going to follow, right? It will cause lymphadenopathy. That's what you call gum focus. Gum focus is produced by the expansion of the tubercle into the lung parenchyma, and the lymph node will become enlarged. And this will happen in the mid and lower zones. When gum focus is calcified, then the name changes. New nomenclature, right? It becomes Ranke complex. Proliferation of the bacilli will continue until about 2 to 10 weeks when cell-mediated immune response develops. If there is failure of that immune response, then that failure will lead to lung damage. Tissue necrotic factor alpha, reactive oxygen, nitrogen intermediates, and the content of cytotoxic cells may all lead to cell damage. And then we have a new nomenclature here, caseating necrosis. The caseous necrosis or miliary tuberculosis, let's go into that. Caseous necrosis is found in tuberculosis, in syphilis, histoplasmosis, cryptococcus, coccidioidomycosis. How about hematogenous spread? Hematogenous spread will lead to what is called disseminated tuberculosis. That is outside the lungs now. All I've been saying before now is all about, pulmonary tuberculosis. Now, extrapulmonary tuberculosis. And miliary TB is just because of the structure, the appearance, that it's going to be like millet, mostly found in children. Hematogenous spread or disseminated TB or extrapulmonary TB would then lead to affectation of almost all organs in the body. It can go to the brain, giving us TB meningitis, to the heart and the pericardium, giving us TB pericarditis, to the kidney, and also people could even have hematuria when the kidney is affected, to the bones, to the vertebra, everywhere, giving us Port's disease. Even in men could give TB orchitis. It's going to affect almost all organs, just like diabetes mellitus. Causating lesions can erode into the airways, and the host becomes contagious at that level, infecting others. So they cough, they have hemoptysis, they have sputum, they sneeze, they speak, they sing, and when the droplets are out, of course, people contacting them will have TB, or may have, depending on their host immunity. If there's no treatment, death will occur in 80% of people. In other words, in some poor parts of the world where people will not be able to afford the medication for tuberculosis, it's not all of them that would die, but majority would do. 80% would die, but 20% will still be alive, even they have acquired the causative agents. So 20% will become chronic or recover, but may not completely eradicate the bacillus, so it will become latent. Reactivation. What will happen to get to that stage? Reactivation is subject of immunity, and of course, we don't need to waste our time. Decreased immunity, HIV leading to AIDS, chronic renal failure, diabetes mellitus, lymphoma, steroids use, tissue necrotic factor alpha and its receptor. Increased age. The older you become, the more the immunity will wane down, and the more the probability of having latent TB being reactivated. Cigarette smoking and alcohol all will lead to increased reactivation. Note, reactivation is localized, less regional, and less causation, typically at the apices of the lungs, may not disseminate unless the individual is severely immunocompromised. There's a concept called remote infection, and with that I will end this presentation for today, and we'll be talking about screening and diagnosis next. Remote infection is infection that progresses to active TB after 2 years. And this is very common to immigrants that have emigrated from their country of origins, and they have probably had active TB in the past treated, and the bacilli not completely wiped off and became latent, or they acquired it, they didn't even know, but because they have strong immunity, it became latent and they couldn't clear it off completely or whatever. Now living in a Western country for 5 years or above, or after living in Western country for more than 5 years, they've traveled back home, and now they're back, and they have fever, cough, hemoptysis, weight loss, and everything like that, chest straight down, everything, sputum, IG, RA, TST, polymerase chain reaction, all done, TB diagnosed. Then contact tracing becomes a problem, right? No. With this concept, remote infection, then we'll have no problem making the diagnosis that based on your country of origin, it's likely we are dealing with remote infection of tuberculosis. With that, I've come to the end of this chapter 1 of tuberculosis. The next chapter will be on screening and diagnosis. And I don't want you to miss it because I want to go into details of everything. So by the time we are done, maybe the 4th chapter or 5th chapter, you have no reason to ask anybody any question as per TB again. Thanks for listening. Kindly remember to subscribe and watch out for the next release, screening and diagnosis of tuberculosis. Thank you.